Thank you very much, Michael. Thank you very much. Very good to see that so many people stay here for respiratory cardiovascular physiology. I think that's really fantastic. There's going to be a little bit of overlap with Katarina's talk, but I don't think that should be a major problem at the end of 3 days of fantastic conference. So these are my disclosures. I don't think that's anything related to the current presentation. And let me just start with this case. So this is a male that was in our ICU recovering from pneumonia. At that time, pH 742, bicaps 25, CO2 41, PO2 96, and tidal volume for him should be around 480 ml. And look right here at his tidal volumes. 10 of PEEP, 0.6 of FiO2, and 5 of pressure support. And if I start the video, you'll see, well, it's a little bit unstable breathing pattern, but in general, tidal volumes are pretty high. If you go on, it's 800 ml, 800 ml, despite low support. And that makes us think, why does this patient have a high respiratory drive? It's not CO2 probably, right? It's not PO2 probably. So why does this patient have a respiratory drive? And when we were discussing that in our group, I went into the literature, and there is some fantastic papers out there. Because you should realize, throughout life, you take about 0.5 billion breaths. And that is to regulate gas exchange, to very narrowly regulate pH. And it's really a fantastic phenomenon, I would say. So I think it's good to go a little bit deeper into the physiology. So first, the definition. I think respiratory drive, what we are discussing in this presentation, is the neural output of the respiratory centers. The respiratory centers, right here. There's a couple of areas right here you will recognize. This is the brainstem, cerebellum. Right here is the nose. Right here is your back. This is an important area, the pre-Butzinger complex. That area contains interneurons that generate the rhythm of inspiration. So respiratory pacemaker cells. And this area is very closely connected to this ventral parafacial region, very close to the cerebral spinal fluid right here, right? And this area contains receptors that are sensitive to H+. And I think there's some great physiologists here in the room, and I have gone through the literature over and over again, but I've never been able to find CO2 receptors. So I would be very interested to hear if somebody knows if there are indeed CO2 receptors. I don't think there are. So the breathing is controlled by H+. There are other centers right here. So this one controls the rhythm of expiration. So we do have different pacemaker cells for inspiration and expiration. That's also nicely shown here. So pacemaker cells for inspiration in the pre-Butzinger complex, for the expiration, and they have different input. For instance, lung inflation will inhibit inspiratory centers and activate expiratory centers. So one more slide on basic physiology, and then I'll get back to clinical work. So don't worry. So right here, this is the whole pathway for generating the tidal volume. So this is the respiratory centers that get input from the body. I'll show you in the next slide. Oh, sorry, there's more physiology coming up. So this is the respiratory centers, activates the spinal motor neurons, activation of the neuromuscular junctions, electrical activity of the diaphragm, generation of flow, and in the end, there's a generation of volume. So there's a lot of steps from respiratory drive to the generation of inspiratory flow. I think this is important as well. Right here you'll see again the respiratory centers, the pre-Butzinger complex, etc., as we just discussed. So what is the input? What determines the respiratory drive? I would like to highlight 3 pathways. First, chemoreception, as already discussed a little bit. pH is the strongest determinant of your respiratory drive. But also the cortical effects. If you want, you can start voluntary hyperinflation right now, but also people working in neuro-ICU will recognize that quite a lot of patients with neurotrauma are actually hyperventilating. As you're sitting here in this room, and especially, I guess, after lunch, the cortex has an inhibitory effect on the respiratory centers. So if there's damage to the cortex, a lot of people start hyperventilating. And finally, and very important as well, there's mechanoirritant receptors in the lung, in the chest wall, in the diaphragm, and other places. And we recognize that as well. A patient with pneumonia on the ER, a patient with pulmonary embolism, but also some of patients with consolidations in the ICU, there's activation of these irritant receptors that provide a positive impact on the respiratory centers, starting hyperventilation. So real quick, strongest predictor of respiratory drive, again, just a little increase in end-tidal CO2 has a huge effect on minute ventilation. And we're not breathing that much because of arterial PO2. Only when arterial PO2 is below 68 kilopascal, it has a strong impact on respiratory drive. I'm going to skip this one. This is what Katarina just discussed. The cortical feedback, I just told you, again, there's an important impact of the cortex on respiratory centers. And this is what I told you as well. Again, cytokines in the lung, infection, do activate these irritant receptors that positively affect respiratory drive. So it says equals, but of course, that's not the case. Respiratory drive and respiratory effort, as will be discussed by Luigi in the next presentation, are different. You can have a very high respiratory drive, but if you have strong respiratory muscles, the effort is still going to be low. So effort is generated by the diaphragm, and if the load imposed on the diaphragm increases, if the respiratory drive increases, you're going to recruit accessory, inspiratory, or even expiratory muscles. I'm sure Luigi is going to cover that. A high drive or low drive may have a negative input. A low drive may be associated with respiratory muscle atrophy, patient-ventilated dysynchrony, and sleep fragmentation. On the other hand, a high drive may be associated with self-inflicted lung injury, maybe, I'm not sure, diaphragm injury, hemodynamic consequences, but very important, a high drive, even if effort is low, may result in dyspnea sensation. So it is important, and it's not the topic of this presentation, so I'm not going to discuss that, but I think it's important in our ICU patients to quantify respiratory drive and respiratory effort. And perhaps Luigi is going to address this. Yes, he's going to address this, so I'm going to skip it anyways. Okay, so back to our patient. So we have this patient, and actually this patient is reading a newspaper. He's doing fine. But if we want to, how can we modulate respiratory drive? It's not that easy, right? Okay, so right here, I think this is actually a nice overview, but I'm a little bit biased, but it is a nice overview. So right here, it shows the input to the respiratory drive, right? Cortical stimuli, chemoreceptive stimuli, mechanical stimuli. We can affect, if we want, respiratory effort directly. If effort is really high, Katarina referred to our paper on partial neuromuscular blockade. If your effort is really low, you can do neuromuscular stimulation. But how can we directly affect the drive? Well, cortex, changing sedation. Chemoreception, ECMO, extracorporeal CO2 removal. Mechanical stimuli affecting ventilator settings, and I think that's going to be the most interesting part. Changing inspiratory support, changing PEEP. First, so these are patients, like our patient, recovering from ARDS. At, in this case, 12 of pressure support and pretty high tidal volume, 9.5 ml per kilograms. So what's happening? as most of us would do, I guess, if you just reduce inspiratory effort. So, inspiratory support, pressure support of 6, tidal volume decreases a little bit, but not that much. But at the same time, if you look at electrical activity of the diaphragm, representative effort, you'll see it increases right away. So you reduce support by the ventilator, drive increases right away. There's an increase, the transpulmonary pressure, the pressure damaging to the lung, does not change at all, but the effort generated by the diaphragm increases. So perhaps in this case, just reducing inspiratory effort might not be the best option. Again, drive increases, effort increases, but transpulmonary pressure remains the same. I think this is going to be really interesting. What is the effect of PEEP on respiratory drive? Patients with ARDS, just an example right here. Airway pressure, changes in esophageal pressure. And as you know, esophageal pressure swings represent respiratory effort. So if we, in this patient, increase PEEP from 5 to 15, you will see that swings in esophageal pressure decrease. So for the whole group, 5 of PEEP, 15 of PEEP. Changes in esophageal pressure, right here 10 centimeters of water, quite consistent. Increasing PEEP, a decrease in respiratory effort. I've tried this quite a lot in my ICU as well. I'm not sure if it is as consistent as here, but in quite some patients, increasing PEEP reduces effort. And then you'll see, obviously, tidal volume will go down. But now this gets really interesting and complicated. Because if we look at respiratory drive, again, remember, respiratory effort goes down if you increase PEEP. But respiratory drive, in some patients it decreases, but other patients increase respiratory drive, while still effort decreases, right? And it took me a little bit of time to understand what's actually happening right here. But this is, let me skip this one. This is how I understand what's going on. So in your patient, you increase PEEP. Drive could decrease, decreasing effort. I think that could be the case if PEEP increased lung homogeneity. Because we just said that consolidation actually activates the irritant receptors in the lungs. So less consolidation, less drive. But in some patients, an increase in PEEP increased drive, but neuromechanical efficiency decreases. How's that? If you increase PEEP, the diaphragm moves downward, becomes at another position on the length tension curve, so it can generate less pressure for the same respiratory drive. And I think that's interesting. Okay, modulation of drive by sedation. Katerina has discussed that, and that's great because I'm running out of time. Very important, as Katerina stressed. I think if you really want to modulate drive, propofol is the first way to go. Don't try opioids. It's not really going to affect your respiratory drive. It may reduce your respiratory rate, but not the drive in itself. So this paper gives a nice overview on the different sedatives on respiratory drive. And of course, but this is theoretical. I think even an ECMO fan like Luigi would not do that. But you can connect the patient to extracorporeal gas exchange or ECMO, reduce CO2, and as Tommaso Mauri did in the study, you'll see the higher the gas flow, sweep gas flow with ECMO, the lower the tidal volume, the lower the respiratory drive. Oops. So I think this actually summarizes it. If you go to the paper, you'll find much more details, but I think this is a topic that is of clinical importance to facilitate a lung and diaphragm protective ventilation strategy. So what I've try to show you in this 15 minutes. First, there's a chemical, cortical, and reflex feedback to the respiratory center. So when you have a patient with high respiratory drive in your ICU, just go through the 3 pathways and see which one which might play a role in the high drive, and you could actually modulate. The high drive, high and low effort may also induce lung and muscle injury. And I think it is important, but Luigi will go into that it is important to modulate drive and try to modulate accordingly. Thank you very much.
Thank you.